Hi, my name is Alexa Renna, and today I will be presenting the following topic of racial disparities in women's health care regarding maternal care. I believe this issue is very important regarding women's health, especially for women of color. Unfortunately, racial disparities are still a major component regarding the treatment an individual is given, which should not be the case at all. I believe this topic is very prevalent now, especially in the two countries I have chosen, which are the United States and Afghanistan. Part 1: Demographics of Health Issues Affecting Women Today. One major issue for women's health is maternal care. According to the World Health Organization, maternal care refers to the health of women during pregnancy, childbirth, and postnatal period. Unfortunately, about 295,000 women died in 2017 following pregnancy and childbirth-related issues. The most common factors leading to death are the following: infections, excessive blood loss, high blood pressure, unsafe abortions, obstructed labor, and other indirect causes such as heart disease or anemia. Around 810 women die every day from preventable causes related to pregnancy and childbirth, according to the World Health Organization. In order to prevent maternal morbidity is to enhance the nutrition of the mother and the baby, treating diseases, supporting women who are exposed to an intimate partner violence, and providing universal access to sexual and reproductive care. According to the World Health Organization, 94% of total maternal deaths across the world happen in low and lower middle income countries. Racial and socioeconomic disparities in the rates of abortion and unintended births and unintended pregnancy exist across the United States and other countries. Experts highlight that these disparities fuel the cycle of disadvantage that is experienced by particular demographic groups, resulting in women not being able to have full control of their fertility. I also posted a chart from 2014 about the causes of maternal death. 27% were indirect causes, 27% was hemorrhage, 13% was other direct causes and complications, 14% was hypertension, 11% was sepsis, and 8% was abortion. And this chart is from the World Health Organization. The COVID-19 pandemic has worsened these disparities, with a recent survey conducted by the International Planned Parenthood Federation revealing that the global delivery of sexual and reproductive health care has been impacted by the pandemic. Vulnerable populations, such as women from low-income and middle-income countries, have been disproportionately affected by the shutdown of and delays in sexual and reproductive care, potentially leading to further preventable deaths and lifelong disabilities. The IPPF found that South Asia is suffering from the largest number of closures of clinics offering these services, and Africa has seen the largest number of closures to mobile clinics. From 2000 to 2017, the global number of maternal deaths per 100,000 live births, known as the maternal mortality ratio, reduced by around 38%. Although these figures are positive and show that maternal deaths are dropping, there still remains great disparities in maternal death, with 94% of women dying during or after giving live birth living in low and lower middle income countries. Around 13% of all maternal deaths are caused by unsafe abortions, with around 47,000 women dying each year due to unsafe abortion. A further 5 million are hospitalized due to complications of unsafe abortion. Black women are more likely to die during or following birth than white women. The Centers for Disease Control and Prevention state that being Black puts women at a 3 to 4 times greater risk of maternal mortality. Experts have concluded that there are multiple factors contributing to this inequality, such as a lack of access to care and poor quality care offered to women at lower socioeconomic levels. Additionally, there has been a recent report that has found that bias and stereotyping are also impacting the level of healthcare that Black women receive, and that it shows prejudice and is playing a part of causing unnecessary death. A greater level of health surveillance and the development of effective prevention strategies are needed in order to protect Black women from these inequalities and reduce the number of women dying unnecessarily during and after childbirth. Training, education, and a focus on reducing racism and bias are key to eliminating racial inequalities in maternal mortality. Part 2: Demographics of Countries. I have chosen the United States and Afghanistan for my two countries about the effects of maternal care issues. What are disparities? Disparities are defined as differences that result in a particular type of health difference that is closely linked with economic, social, or environmental disadvantage, are complex, and are the result of numerous factors including social, environmental, biologic, genetic, behavioral, as well as healthcare factors. Quality of healthcare is critical for improving outcomes for racial and ethnic minority women. In the United States, there are significant racial and ethnic disparities in maternal morbidity and mortality. Black women are 3 to 4 times likely to die of pregnancy-related death as compared to white women. Non-Hispanic Black women are 3 to 4 times more likely to die from pregnancy-related causes than non-Hispanic white women. This disparity in maternal death, defined within 1 year of pregnancy, caused by a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of unrelated condition by the psychological effects of pregnancy, has existed for over a century and has actually widened over the last 100 years. This is currently the largest disparity among all the conventional population perinatal health measures. Non-Hispanic Black women have had the fastest rate of increase in maternal deaths between 2007 and 2014, and have maternal death rates up to 12 times higher in some cities than non-Hispanic white women. Pregnancy-related mortality is also elevated among Native Americans and Native Alaskans, Asians, Pacific Islanders, and for certain subgroups of Hispanic women, including Puerto Ricans and Pacific regions within the United States. For every maternal death, 100 women suffer a severe obstetric morbidity. Severe maternal morbidity affects greater than 60,000 women annually in the United States. Non-Hispanic Black women have the highest rates for 22 of 25 severe morbidity indicators used by the Center for Disease Control to monitor population estimates for severe maternal morbidity. I also included a chart that discusses the no chronic conditions, the physical health conditions, behavioral health conditions, or multiple chronic conditions that influence women's severe maternal morbidity for non-Hispanic white women, non-Hispanic Black women, Hispanic women, Asian or Pacific Islander women, or American Indian or Alaskan Native women. So not only do Black women have higher case fertility rates, they also are more likely to experience illnesses and pregnancy complications. They do have a higher risk rate of hemorrhage, asthma, cardiac events, hypertension, and infections. Other risk factors are no prenatal care, advanced maternal age, low levels of education, and low socioeconomic status. Prenatal care is still administered unfairly between racial, ethnic, and socioeconomic groups. African American women and other low-income women have been highlighted as specific groups for this case. Currently, more than 1/3 of all U.S. births are financed by Medicaid, and disproportionately, a large number of these Medicaid-covered births are among minority women, including Black women, Hispanic women, Black non-Hispanic women, and Asian Pacific Islander women. Hispanic women were significantly less likely to have had no Medicaid coverage prenatal care visits compared with white non-Hispanic women, and women in minority racial ethnic groups were less likely to have begun Medicaid-covered prenatal care 5 or more months prior to delivery. Breastfeeding is beneficial to almost all mothers and infants, but the benefits may be significantly greater for minority women. Minority women are disproportionately affected by adverse health outcomes, which may improve with breastfeeding. Relative to white women in the United States, African American and Hispanic women have increased rates of obesity, diabetes, and cardiovascular disease. Women who breastfeed exclusively are more likely to lose weight postpartum than women who breastfeed non-exclusively and formula feed. African Americans continue to have the lowest rates of breastfeeding initiation, which is about 60%, and continuation at 6 months is 28%, and 12 months is 13%, compared with all other racial ethnic groups in the United States. There are some improvements, however, from 2000 to 2007. However, African American mothers are still 2.5 times less likely to breastfeed than white women. And currently, African American women are not meeting any of the Healthy People 2020 objectives for breastfeeding. Hispanic mothers are slightly more likely than any other racial or ethnic group to provide formula supplementation as early as 2 days of life. Compared with white women, Hispanic and African American mothers are more likely to introduce solid foods before 4 months of age, have higher rates of maternal restriction feeding practices, and lower rates of exclusive breastfeeding. Ethnicity is a risk factor which is associated with maternal and newborn health even in developed countries where adequate health facilities are available for all. However, the difference in health is more visible in developing countries, especially in refugee camps. Studies in the developed countries have associated ethnicity with poor neonatal and newborn health through factors such as maternal physical health, health awareness, and maternal social status or education. In a certain study, it was determined that there was a high ratio of maternal deaths and a lifetime risk of death for Afghan refugee camps as compared to Pakistan mothers. Nearly 70% of the risks were preventable. Afghan refugee mothers are at a higher risk of low birth weight as well. Key determinants of mental disorders are the following: poverty, income inequality, interpersonal and collective violence, and forced migration. Social determinants include demographic, environmental, sociocultural, and socioeconomic factors. Women living in poverty and extreme adversity and facing multiple threats are the most vulnerable. Afghanistan is one of the poorest countries globally, and nearly half of the population lives below the poverty line with high levels of food insecurity. Despite an increase in the number of health facilities, midwives, community health workers, and services available for pregnant women, new mothers and their infants, and the percentage of unattended births remained high. In 2015, only half of all births in the country were attended by a health professional. Depression is the most common of the mental health challenges and is twice as common among women than men. Almost 87% of 215 Afghanistan women were presented with some symptoms of postpartum depression. The following symptoms for postpartum depression in the picture that I posted below include difficulty sleeping, lack of energy, low sex drive, changes in appetite, weight loss or gain, increased anxiety, feeling hopelessness, guilt, sadness, or fear of being alone, irritability, difficulty concentrating, and scary thoughts about a baby or concern for the baby's health, which is different than baby blues, which can be I'm not feeling myself, or still some forms of anxiety or irritability. It's just a more extreme case. So mothers of children with moderate or severe acute malnutrition were more likely to have depressive symptoms or symptoms of postpartum depression in Afghanistan. Afghanistan has a high maternal mortality rate of 400 per 100,000 live births. Although direct causes of maternal morbidity or mortality in Afghanistan include hemorrhage, obstructed labor, infection, high blood pressure, and unsafe abortion, the high burden of diseases responsible for maternal mortality arises in large part due to social determinants of health. Healthcare factors were identified as the major determinant in particular studies. Accessibility, lack of healthcare professionals, and variability in the utilization of healthcare services were also major issues for Afghan women in maternal health care. In a study of maternal mortality conducted in Western Afghanistan, it was found that only 63% of the health facilities listed by the World Health Organization as functional were in operation. All health facilities with emergency obstetric centers were located in one district, which was not accessible by women in any of the rural districts. And a reproductive health knowledge, attitudes, and practices survey in the capital, Kabul, it was found that 18.2% of the population thought that the health facility was too far away, and 14.2% reported that transportation to the medical facility was a problem. Education levels has been associated with improved healthcare utilization, increased birth spacing, and empowered women. Women's education, irrespective of other socioeconomic factors, had positive contribution to improved reproductive health. 93% of Afghan women who died due to maternity-related causes were illiterate. It is reported that in Western Afghanistan, less than 5% of pregnant women had ever attended school. Societal practices such as early marriage, rights surrounding sexual practices, and need to obtain husband's permission to receive health care all have a major impact on women's health in Afghanistan. A study found that in rural Western Afghanistan, 47% of women became pregnant before the age of 16. Around 83% to 75% of Afghan women expressed that it was a wife's duty or obligation to have sex with her husband even if she did not want to have sex. Part 3. Cultural similarities and differences. For both cultures, women's maternal care is affected by their socioeconomic and education factors. Racial and ethnic groups in the United States are affected by disparities in maternal care because of their level of education and socioeconomic factors. The lack of education causes a lack of jobs and income, which also makes healthcare in the United States difficult to obtain or afford, like health insurance. Racial ethnic groups in the U.S. have a higher chance of becoming ill as well because of the low income and the low poverty. Afghanistan women also live in lower income neighborhoods and can only leave their neighborhoods if their husbands are wealthy. Afghan women cannot attend school or only attend until secondary school. They do not attend or complete school because of the power-gender dynamic in Afghanistan. The lack of education makes it difficult for a woman to work, and they also make no income. They lack certain health resources and other essential items which the U.S. can easily obtain. They lack simple human rights as well compared to the United States, which is truly saddening. Part 4. Ethical considerations and action for the United States and Afghanistan. Healthy People 2030, which provides a 10-year national health objectives, identifies the prevention of pregnancy complications and maternal health deaths and improvement of women's health before, during, and after as a public health goal. Growing recognition of disparities in the United States has prompted efforts from clinical groups and public health officials to become more informed and address certain biases, practice decision-making, and listen to the concerns of minority pregnant women. A number of initiatives are underway for Medicaid to improve maternal and infant health and reduce disparities given the substantial role the program plays for low-income pregnant women and children. As of today, the United States and members of NATO have withdrawn their forces in Afghanistan, and the Taliban has once again taken over. The Human Rights Watch visited health facilities in Kabul, which is the capital of Afghanistan, and interviewed 34 women about their experiences seeking and receiving health care. The women expressed that they face risky pregnancies because of lack of care and undergo procedures that are not deemed safe. The woman expressed fear as well that the Taliban would take control of their lives once again and that the health care would diminish, especially for women. The only thing being done now is donors and organizations are delivering services, although it is difficult as of right now. In conclusion, racial and cultural disparities affect both of the country's women today. Maternal care is a major health issue for women, and it must be treated so. Maternal care, sadly, is still not deemed as important in other countries like Afghanistan, and women and children have to suffer because of this. It is also important to acknowledge how women in America still face discrimination because of how they look or their particular education level and are not treated equally the same in the healthcare field. As women, it is our job to emphasize the importance of maternal care globally and to make sure every woman everywhere, no matter the race, ethnicity, or socioeconomic background, is treated the right way for maternal health care. Here are the sources I used for the presentation. Thank you so much for listening. I hope you enjoyed, and I hope that you learned more about racial disparities in maternal care regarding the United States and Afghanistan. Thank you and have a nice day.